Well, welcome back, everybody. It's actually my pleasure to introduce the moderator for our next panel. Our new elephant in the room is COVID. You heard a little bit about that yesterday, people trying to decide strategies to deal with this new reality. Our moderator for this panel is Bob Twillman. Bob's been a leader in national pain policy and advocacy for over 15 years. He's a former executive director for the Academy of Integrative Pain Management. He served for 7 years as chair of the Prescription Monitoring Program Advisory Committee for the Kansas Board of Pharmacy. Earlier in his career, Bob was a full-time faculty member at the University of Kansas Medical Center, where he founded and directed the inpatient pain management program and was co-founder of the hospital's palliative care team.
What is this one about?
Bob is on the Practical Pain Management Editorial Advisory Board, and he's currently serving his community as a pain management psychologist at St. Luke's Health System in Kansas City, Missouri. And Bob, looking forward to this presentation. You've got a very interesting group of panelists, and I'll turn it over to you.
Thank you, Kevin. Yes, it's not often that you find a panel that's composed entirely of lawyers and physicians, and they all get along as well as this group does. So I'm really looking forward to hearing from each of them. Our panel today is going to consist of Dr. Paula Gardner, who's an associate professor in the Department of Family Medicine at Boston University School of Medicine. She'll be followed by Kate Nicholson, who's a health policy and civil rights attorney. And then we'll have Dr. Andrei Ostrovsky, who's a pediatrician, managing partner of Social Innovation Ventures, and former chief medical officer for CHIP and Medicaid at the Centers for Medicare and Medicaid Services. And then finally, we'll have Daniel Blaney Cohen, senior legislative attorney from the American Medical Association. If I can have my slides up, I'll do a brief introduction to the topic. Today, we're going to be talking about innovation in pain management delivery as a response to opioid misuse and overdose and to COVID-19, as Kevin mentioned. Next slide, please. I kind of look at this as what's happened in the context of COVID-19 from the perspective of the good, the bad, and the ugly. There are a lot of changes that have happened very rapidly. 2.5 months ago, I was still seeing patients in my office every day doing my usual thing. And for the last 6 weeks, I haven't even been to my office. I've been seeing patients entirely from home via televideo. It's been a tremendous change very rapidly. It's happened to us. The nature of COVID-19's effects on the ability to deliver pain to people really varies widely and depends on a number of factors. And many of those will be elucidated during the panel discussion. Some of the changes present some significant opportunities to improve pain care, while others represent threats to people with pain and their clinicians. We don't know what the long-term impact of COVID-19 on pain care will be, but it's something that's very worthy of our attention because some of those opportunities are things we need to hone in on and be sure that we're able to sustain those benefits that we find as a result of this experience. Next slide. So some of the good things that have happened, we've seen increased access to some types of care through telehealth applications with improved payment for those applications. So as I mentioned, I'm seeing patients entirely via telemedicine at this point. That was not even possible for me in the middle of March. In fact, even by the end of March, that still was not possible for me to do that. But now we're able to do that, and it really benefits a lot of people. We see people from a wide geographic area. I have patients who drive as much as 3 hours to come to appointments. And so for those folks, it's really not tenable to ask them to jump in a car and drive 3 hours to be seen once every couple of weeks. So we have opportunity to take our services to people who ordinarily wouldn't be able to access us. We'll hear during the panel about some innovation in complementary and integrative treatments, so the telehealth delivery of those types of treatments is possible. And I think we've also seen, as a result of COVID-19, some lowered barriers for prescribing for pain and opioid use disorder treatment that have potential, again, to benefit patients. Next, please. But it's not all good. Some of it's not so good. We have expanded access to people, but if people don't have the technical savvy and or the up-to-date technology, they may not be able to use the telehealth applications. I have a couple of patients who I can only talk to on the phone. They're still using flip phones. They have computers that don't have cameras. And so we're really limited to just the audio portion of that interchange. Some treatments, even some self-management treatments, are not available to patients now. So it's really disrupted their continuity of care. I have a number of patients who receive regular injections, epidural steroid injections, nerve blocks, other types of injections. They haven't been able to get those since the middle of March. Patients who I have who were doing a lot of self-management by going to the gym and getting good exercise, not able to do that. They have to find alternate ways of being able to do that. Increased access for people with pain doesn't mean that more clinicians are available. Some of you may have seen, I wrote a piece for the newsletter for AACIPM, where I talked about, in effect, what we might be doing here is widening the mouth of the funnel without making the spout any bigger, because we're giving access to more people, but unless we also increase the availability of clinicians, we're just creating more of a backlog and more frustration for people. The increased baseline stress that comes along with COVID-19 is increasing everyone's anxiety, and I think over time increasing their depression as well, which in turn increases pain, makes it more difficult for people to do the things they need to do to help manage their pain. And we're also seeing some exacerbation of some of the social determinants that go into the problem of chronic pain. And again, that's something we'll hear more about during the panel. Next, please. And then there's the ugly. We know that people with pain often have conditions or treatments that make them more vulnerable to catching the virus and dying as a result. Many of the conditions that cause chronic pain are conditions that make people more vulnerable. Some of the treatments that we use for things like rheumatoid arthritis and other conditions make them more vulnerable. And so as a result, we see that many of our patients are among the most vulnerable and need the most protection from the virus. Next, please. Okay, Paula, take it away.
Okay, great. Next slide, please. So as the panel came together, we had a really exciting conversation about what is the best way for us to share this perspective now that COVID is here. In a way, the cart is before the horse, in that some of the innovations that are happening, like telemedicine or different prescribing standards, are ahead of where the evidence is. And we're sort of in a little bit of a catch-up time to wait for the research to come out. So to bring some context to this, we thought one way we could all get behind this is to actually give you a clinical vignette. And I'm going to present the clinical vignette. Next slide, please. I have nothing to disclose. Next slide. And for my learning objectives, I really want to just describe how my practice has changed as a primary care provider, and then really highlight some of the barriers that my patients are having. Next slide. Fantastic. So I'm a family medicine physician, and I work at UMass Memorial Healthcare. And I'm also a chronic pain researcher and health disparities researcher, and I wear both hats. And during the time of COVID, my chair has said, Paula, you know, right now you need to be on the front line. You need to be a clinician in the field helping with COVID. So I created a case that brings together what I've been seeing in the COVID testing patients, and also what I'm seeing using telehealth with my primary care provider patients and my integrative medicine patients with chronic pain, to try to bring some context or real life experience for you. And so this is a patient that I saw who was a 33-year-old female. And when she came into the COVID tent, she actually brought her 3 daughters with her. She was an African-American female, single mom, and she was living in a 2-bedroom apartment with her 3 daughters. She was working at McDonald's at the time, and a fast food restaurant, I apologize. And 2 of her colleagues at the fast food restaurant were COVID positive. And so she was very concerned for herself. She was having some coughing, she was feeling feverish, and she was very worried about her daughters getting exposed. So she came in for testing. And so we did test her. You know, in that process of determining that she had COVID, you know, she told me some of her other story, which was that she has a past medical history of having chronic pain, and she hasn't been in touch with her clinician. So she has her medications to get refilled, but she hasn't been able to get her clinician to put those prescriptions in for her. And she also told me that she had been seeing an acupuncturist, but that had been canceled, that she wasn't getting access to her acupuncturist because they closed because they were not considered essential. The other thing that had been canceled was her physical therapy. So she had been using acupuncture and physical therapy and medications to help her with her pain, but she didn't have this toolbox anymore. So let's go to the next slide. So I wanted to sort of create this scenario for you so you could see, where does this patient sit in our perspective. So first of all, just talking about her mental health, and does she have access to her mental health? You know, she is so at risk for depression right now. Of course, having tremendous anxiety about, is she going to be able to provide for her daughters? What's going to happen to her job? And then just anxiety around the pandemic. It also puts her at higher risk for substance use. Then, of course, there's her physical health. What is it for her to be a patient with chronic pain and have COVID? How does the virus interact with how her body's doing and the symptoms of her chronic pain? You know, we don't really have definitive research now around patients who have COVID, and does it make their chronic pain worse? Does it make it better? We just don't know. And then also for her interpersonal relationships, a lot of her family who had been available to her to help her with her daughters and support her, you know, she was socially distancing with. Her daughters had also been at home with homeschooling because the schools had been shut. So her interpersonal relationships with her daughter, her role was with her daughter, and the lack of access to her supportive family were big issues for her. And then for her physical functioning, I think, you know, she was feeling really sick, and that really influenced how was she able to take care of herself, how was she able to take care of her body. And the other really important thing to know is that she was in an apartment with 2 bedrooms. So when I told her about the importance of social distancing, and she looked at me and she said, well, I don't have my own bathroom, right? And I can't really social distance. I can't stay 6 feet away from my family in that space that I'm living in. So I think that these also brought up increased risks. And then again, definitely for occupational, you know, she was a person who was working paycheck to paycheck. And so I really think that COVID is going to really affect our patients on work disability or who are, you know, living paycheck to paycheck, and that could really aggravate chronic pain, the stress. So next slide. So what's really important here is just to remember that we don't really know in this moment how COVID is going to affect our patients in the long term. And this is a slide that has the modifiable risk factors and the non-modifiable risk factors. So we know things like age and gender, those are not going to be influenced. But I did want to just bring up this point about adverse childhood events, because I do think that for my patients, COVID is making post-traumatic stress disorder worse. COVID is bringing up a lot of trauma for people, especially in social isolation, and that is making their pain worse. And then I think there's also a big concern around people's families and their children, and how is this going to be affecting their children in the long term as well? And will we have a generation of children who live through the COVID pandemic and are going to be more at risk for chronic pain in the future? And then in terms of our modifiable risk factors, I think we really talked about many of these before, but I just want to bring up that I do see clinically now that my patients with chronic pain are not sleeping, so their sleep dysfunctions are worse. And also because they're home, they're seeking relief for their pain. And what I'm noticing, one thing is that people are eating a lot more. I mean, maybe you're eating a lot more. I know I'm eating a lot more. And one of my patients said to me, I think that I've gained the COVID-14, where she was recommending, remembering when she was in college, how she had gained 14 pounds as a freshman. And now she feels like she's gained 14 pounds because she's at home socially isolating and doing a lot more eating. So I think like these are the things that we don't know how will affect chronic pain. Next slide. The other thing that's important for us to think about is the cultural context of chronic pain and COVID, and how is it that our patients from different cultures might be experiencing things through the lens of their own culture. Things that were helpful for them in their toolbox, like social support or spirituality, religion, home practices, these things are all have been disruptive. And I also know that for myself, as a primary care provider, we've had a lot of people not come in to the hospital, not come in for their, when things are getting worse. So people who do have extreme pain may be staying at home because they're afraid to come to the hospital because of the pandemic. And I know our hospital is getting ready for sort of a wave of people who've been staying at home, not having appropriate treatment, things like strokes or chronic pain flares, they're staying at home and not getting treatment. And so now we're expecting this new wave of people coming in with untreated conditions. Next slide. So, this is the way I feel right now as a primary care provider and an integrative provider working with chronic pain patients, that I'm trying to figure out how to do this with telemedicine. And it's definitely, I think telemedicine is here to stay. But it is a new learning curve, and we just don't know what are the pros of using telemedicine for chronic pain and what are the cons. Next slide. So as Bob said in the very beginning, there are some definite benefits for using telehealth for treating patients with chronic pain. One thing that's been very interesting is the new standards around prescribing medications for chronic pain. And I don't know what's going to happen. I don't know if some of those loosening of you doing different blood testing or urine testing, or the amount of medication you can prescribe, I don't know if those will be reinstated or relaxed. We don't know. But I do think it's so important to remember that our patients who were on the edge of living in health disparities, living paycheck to paycheck, have been made more vulnerable during this pandemic. And I see that firsthand. And then lastly, I just wanted to say about essential care, because to me, as a primary care pain doctor, acupuncture is essential and physical therapy is essential. And so as I was trying to work with patients in a non-pharmacological way, to me, that was the treatment of their choice, that's what was working for them. And when those therapies became not essential, we lost access to those. So I think in the post-COVID world, we need to figure out how to redefine what is essential for pain care. Next slide. Okay, so now we'll move on to Kate.
Next slide, please. Good morning, everyone. I'm going to talk a little bit about the consequences for patients in pain in light of COVID. Next slide, please. So just the background that we're coming into this with, we have an existing crisis in which pain is inadequately treated relative to its prevalence and disabling consequences. I think everyone probably in this webinar will agree with that. We have the overlay of the opioid and overdose crisis on access to medication and access to care that was happening before COVID-19. A couple of studies that came down in the last year, one at the University of Michigan suggested that 40% of primary care physicians will not see a new patient who uses opioids to manage pain. And a more recent study by the Center for Addiction and Quest Diagnostics suggested that 81% of primary care doctors are quite reluctant to take on these patients. And now we have a whole new set of problems and disparities that have arisen from COVID-19 and from our efforts to contain spread of the virus. Next slide, please. So we're dealing with a vulnerable population. Bob mentioned a bit of this. Many of the diseases that cause chronic pain leave patients immune compromised. I'm one of those patients who did get COVID, so this is not an abstract thing for me. Many people with chronic pain have multiple comorbidities, which may increase their risk factors. Many of the treatments for pain-generating conditions leave people immune compromised, everything from chemotherapy for cancer to steroids to even opioids. And one of the things that's been really frightening but also interesting about COVID-19 is the light it has shined on health disparities or social determinants of health. You know, we've seen sort of that it very much disproportionately affects people of color, older Americans, and people with disabilities. And I just want to make the point that those same health disparities exist in pain treatment. I think most people recognize that pain may increase with aging and that pain is a major worldwide cause of disability. With respect to race, it's a little more complicated. There are studies that show that doctors underrate the pain of people of color, but there are also more recent fMRI studies showing that people of color may actually experience a higher degree of pain than their Caucasian counterparts, largely because of these determinants and trauma. And of course, because the way that we have waged the drug war in this country disproportionately against people of color, they're also more often perceived as drug seeking and therefore they have their concerns dismissed. Next slide, please. So I'm going to talk a little bit about access to medication and access to care in light of COVID-19. We have seen a new emerging access to medication issue. Basically the hoarding of anti-malarial drugs. There was a study published recently that showed a spike in sales of these drugs tripled after public figures lauded them as treatments for COVID-19. And one of the reasons that this was a problem is that there are patients with pain-causing conditions, people in pain from lupus and rheumatoid arthritis, who rely on these medications regularly and are unable to obtain them. Next slide, please. And then we've seen continued problems with access to controlled medications. We've seen a sort of supply side issue with a shortage of opioids for ventilator patients. The good news is that the FDA and the DEA are working to shore up the supply chain, and the DEA has raised its quota or opioid ceiling by 15% in response to COVID. But I think it's also important to point out that the DEA made fairly dramatic sort of one-size-fits-all quota-based cuts. And we've seen problems in the past that emerged from these quotas. In 2018, when there were some manufacturing difficulties, there was a shortage of injectable opioids for hospitals. And today, the lowered quota has been affected, we see, with the pandemic. So we have a higher need. Next slide, please. But we've also, as others have mentioned, seen some really positive changes. The DEA has authorized an exception to the Ryan-Hatch Act that permits providers to prescribe controlled substances based on a telemedicine visit without a prior in-person visit or a telemedicine visit outside a DEA registered facility. So that's a really positive change at the federal level. I've heard from patients for whom this works really well, but I have also heard from patients in states where it's not permitted by state law, or where people have had sort of insurance barriers to having their medication prescribed this way. So while it's a really positive federal effort, there are still significant gaps in the different states and in implementation. A really interesting concern was raised by a number of palliative care doctors recently that suggests that perhaps this isn't going far enough, in particular with respect to elderly patients who may be quarantined alone and may not have access to audiovisual technology. These doctors suggest that in that circumstance, and especially because these are patients who are likely to continue to be limited and sheltered due to heightened risk, that perhaps telephone visits could be sufficient in this time. And finally, I do still hear from patients all the time who are denied care or denied prescription fills for controlled substances. I recently received an email from someone whose doctor was sick, presumably with COVID, and the on-call physician refused to treat her, to continue her opioid prescriptions. Next slide, please. Ironically, the barriers we've seen are in sort of hands-on care or in-office visits. It's been wonderful to see expanded use of telehealth, but a lot of the maintenance care for pain, including many of the integrative treatments we address, everything from massage to dry needling to chiropractic to osteopathic, hands-on manipulation, craniosacral, acupuncture, have largely been closed. And there can be real consequences for people in pain who use these maintenance treatments to keep an equilibrium in their condition. Flare-ups can last for a very long time. We've also seen that screening and routine blood work has been postponed. I had gotten a note from someone on Twitter saying I was supposed to see a rheumatologist last month. We were making progress in figuring out why I'm in constant pain, and now it's just eternal limbo. Labs need to be done. Telehealth is no use. I was so close. And we've also seen that a lot of the interventional and non-emergency surgical techniques have been postponed. Next slide, please. So this is an article that appeared in Vox, and I raise it partly to discuss Danya Polanker's story a little bit. You heard from her yesterday. She's a research professor in sort of health insurance and reforms at Georgetown, and she's someone with chronic pain. But the reason I raised this article is that the author was talking about the way in which that so many of these treatment providers are solo practitioners, and that many are threatened to go under permanently because of the closures. So it may be that even as we begin to reopen some of these, quote, non-essential services, we will continue to see gaps in care because practitioners were not able to stay open. Next slide, please. So the article follows Danya as she drives to Philadelphia from DC to get nerve blocks because the clinics in DC are closed. And I think she makes a couple of really excellent points in the piece. One is the question of whether maintaining your health is urgent care. It's not something we usually put in the box of urgent, but if we don't take care of it, things may become urgent or emergent. And then on the consequences for someone with chronic pain, she said, I feel very intense pain pretty much everywhere in my body. Yeah, it's not life or death, but it's not just quality of life either. There's pain that impedes your quality of life, and there's pain that impedes your life. And she goes on to talk about how before getting the block, she was unable to care for her daughter or play with her daughter. Next slide, please. So this has been raised a little bit, but I wanted to just mention that there have been real consequences of isolation for people in pain. People in chronic pain are already at higher risk for depression, anxiety, and suicidal ideation. I've given a lot of talks on resilience, and one of the key things is having social and cultural supports. They're a big part of maintaining mental fortitude, and those have not necessarily been available to people. There are practical consequences for people in pain who require the assistance of caregivers. This can be family caregivers who can no longer stop by and check on them because of isolation, or paid caregivers who don't have sufficient PPEs. And this is a big issue in the disability community where a lot of care is just been dropped. And for some, this may mean relocation into an institutional care setting, which, given the exposure rates we've seen in long-term care homes, is probably the last place any of us would want to be right now, and certainly the last place that you would want to put someone who's already potentially more vulnerable to COVID. And lastly, I just want to very quickly say, so that I end on a positive note, in the civil rights and disability rights space, we talk a lot about the social model of disability. And by that, we mean that it's really how we organize our society in terms of who we include and who we exclude that has a bigger effect than individuals' impairments. And I think now we've just all experienced a little bit of social isolation, a little bit of virtual life, and the things that a lot of people with disabilities have argued for a long time. And so I hope that we've captured the public imagination, the imagination of the healthcare system, and of policymakers to continue using telehealth and some of these innovations that are so much more accessible to many people. Thanks so much.
Thanks a lot, Kate. That was terrific. Next slide, please. So I will add to the theme we've been discussing to date, and in particular focus on some macro trends that have implications from a payment perspective and also from an innovation perspective. Next slide, please. I'll be mentioning some companies that I'm an investor in, so take everything I say with a grain of salt. Next slide, please. I gave a talk about just shy of a month ago now. Let's see, today's the 14th. And I had this slide at that time. There were just shy of 42,000 deaths in the US. Next slide, please. This morning, 82,000 deaths. It's pretty remarkable how many people are dying on a daily basis from COVID. And as Kate mentioned, as others have mentioned that have gone through COVID, I brought coronavirus home early March after I was on service at the hospital. Fortunately, everyone did okay at my house, but people we know and love are unfortunately passing away and suffering on a pretty tremendous level. Next slide, please. And this is not just on a medical level. This isn't just from a healthcare level. This is much more profound, and this is also data I shared at that same presentation on 4/22. And next slide, please. As of most recently, we went up from 22 to 36 million people that are unemployed. And if we put into context the unemployment rates compared to other recessions, we're trending towards the Great Depression, which is pretty remarkable. And here's why this is so important for chronic pain. Next slide, please. So there's been some pretty good research lately tying together socioeconomic status and deaths of despair, in particular overdose deaths, deaths from alcohol cirrhosis and suicide. This slide in particular highlights the mortality rate amongst 50 to 54-year-old white non-Hispanic people in the United States. And if you look at the trend line and compare that in terms of the timing, you can see how there is some temporal association between what happened in the early 2000s and further acceleration of mortality rate and what happened in the most recent recession. And unfortunately, what we're probably going to continue to see is the mortality rates will now once again peak, and the mortality rates will continue to perpetuate disparities. And if we think back to what Paula was talking about with that beautiful visual in terms of modifiable and non-modifiable risk factors that interplay with COVID, we have to very seriously take this into account, and especially what Kate was referring to, those specific anecdotes of how, at what point is it quality of life, at what point is it just life. These unemployment numbers are going to have a profound impact on people having even access to healthcare, assuming they can actually go to see a provider. Next slide, please. And so what needs to happen here? Well, a lot needs to happen. I think we've had speakers reference solutions that I think are very important. I'll focus in particular, at least from a policy lens, on the Medicaid space. There's some very relatively straightforward solutions that will dramatically improve care for people with chronic conditions, and in particular people with chronic pain. There was a recent increase in the FMAP, the federal match that goes out to states. The average is roughly 65 to 70 cents on the dollar that the federal government pays in terms of Medicaid funded care at any state level. It depends on the state's relative level of wealth. The recent policy changes have led to a 6.2 increase in FMAP, which is pretty significant. And there's pretty strong consensus among specialty societies, advocacy groups, other Medicaid experts that we really need to get to at least a total of a 12% increase in the FMAP above what currently exists, so that states have sufficient funding and support, so as one, not to go bankrupt, and two, to provide adequate funding for the dramatic increase in Medicaid enrollees. Additionally, for the existing Medicaid providers serving the existing Medicaid populations, increasing payment to them so that there's at least parity to Medicare rates, if not higher in some cases. And then there's also the option of expanding Medicaid. And we have several states that still have not expanded Medicaid, and I won't even go into work requirements or block grant considerations, because those absolutely should be completely dismissed, as they will be completely counterproductive to COVID-related efforts around chronic conditions, especially chronic pain. Next slide, please. So while policy is getting figured out, and we have the fourth stimulus package that's being deliberated, $3 trillion package that's been proposed by Nancy Pelosi, we have interventions that are available now that, in particular, in the setting of social isolation, social distancing, that could have some pretty significant impact on people with chronic pain. So I'm going to share 4 interventions that could be quite impactful. The first one is a technology which I found quite interesting. It's a non-pharmacological way to manage pain, and it's done entirely virtually. It's an approach that requires a virtual reality headset, and that headset has baked into it cognitive behavioral therapy, deep breathing exercises, mindfulness exercises. And if we go to the next slide, it can be quite powerful in being an adjunct or as a primary modality in addressing acute pain, emerging literature around chronic pain, and emerging literature around also anxiety. If we go to the next slide, please. There's several published randomized controlled trials that have reproducibly shown this effect size. Now, the constraint here is the research has predominantly been focused on acute pain. There is ongoing research right now around chronic pain and around anxiety, as I mentioned. Next slide, please. And this technology is quite far along in the FDA pipeline, but importantly, right now, consumers can go get the technology that is the non-prescribed version and benefit from it already. I actually use it a year and a half ago, or was introduced to it a year and a half ago when I tore my Achilles. Next slide, please. There's another issue of how to help with support, help with isolation, and help with care coordination. And that is already hard to do, even pre-COVID times. But at least there was the option of in-person community health workers or a case manager. Now that that interaction is substantially decreased, there are platforms like this one here, Inquisit Health, which are purely virtual, but human peer or community health worker that helps the consumer with addressing a chronic condition, but also with care coordination needs. Next slide, please. In terms of the evidence for their intervention, what they've done, which is actually what I tend to favor as an investor, is they've actually taken an existing body of literature and they happen to have just digitized it. So the literature for peers and the literature for community health workers is quite strong. And what they've done is just made that accessible to people without having to have that direct in-person interaction. And so it's done virtually. Next slide, please. The final technology I'll share, and again, this is more of a service intervention, just happens to be augmented by technology, is, there's a limit to the level of pain control that can be done non-pharmacologically. There's a limit to the care coordination that can be done by peers. What if someone needs to get assessed and needs really like urgent care level of services? And so how do we avoid exposing more folks to the spread of coronavirus, but also how do we actually just create a more consumer-friendly experience and not have to subject ourselves or subject our family members to having to go through the pretty arduous process of going to an emergency room or going to an urgent care center. So this company called Ready Responders has created a pretty powerful intervention whereby they actually send the paramedic to your home or the EMT to your home. And what's nice is they have the hands-on ability to actually do a physical assessment, but they also have a telemedicine physician there to complement that hands-on component with the EMT. Next slide, please. And now I have to caveat, this evidence is very preliminary, it has not been peer-reviewed, unlike the preceding two interventions. But at least in the preliminary level, directionally speaking, this is a quite an interesting intervention. And when we're thinking system-wide, what will be the new normal? To what extent is care really going to be provided virtually relative to back in person? Interventions like this are pretty interesting. And finally, next slide. As we're thinking about policy interventions, or as we're thinking about technology innovations, in the backdrop, we have to think about upstream health determinants. And Paula alluded to several of them, but one in particular is stigma. And there is some very promising work that's emerging out of an organization called Shatterproof. And their anti-stigma work is focused primarily on opioid use disorder. But the lessons from that work and that program are very translatable and frankly should be deeply incorporated with the stigma around chronic pain. And so I think as we look forward to what will happen in the end game of coronavirus, we have to keep in mind that we're perpetually have to be reminding policymakers, payers, health systems about the very important issue of stigma. Next slide, please. And with that, I'll shift it over to Daniel.
Thank you, Andre. Hi, let's go next slide, please. Hi, today I want to talk a little bit about the, from the AMA's perspective. My name is Daniel Blaney-Cohen. As Bob said, I'm an attorney with the AMA's Advocacy Resource Center, which is the state government affairs unit at the AMA. And I want to try to tie together, somewhat my colleagues have shared and present the AMA's recommendations to help patients with pain, not only during the pandemic, but as states begin to reopen. And with the one big caveat, I'm an attorney, not a clinician. So I'm going to, everything will be focused hopefully on a more of a policy focus. Next slide. I'll go through the slides, and there's a lot of words on some of the slides, so I'm not going to go through them in detail. They're all available to you. But the main point with the learning objectives, pre, during, and post-COVID, I think raise a couple of similarities and differences. One of the most common points that I want to emphasize, and I'll talk about this throughout the presentation, is that if policymakers don't take action to help patients with pain will continue to suffer as a result of insufficient and/or arbitrary policies to provide access to evidence-based care. And one of the fundamental principles that from the AMA's advocacy perspective is that patients with pain deserve the same level of compassionate and comprehensive care as any other patient with a medical disease. And the COVID pandemic doesn't change that fundamental principle. Next slide. Let's take a quick look at the policy landscape. Next slide. Let's get a few things really clear. Patients with pain, whether chronic pain and cancer, or who have received hospice or need hospice palliative care, did not cause this nation's epidemic, what's commonly referred to as the opioid epidemic. The AMA does not support illegal pill mills or fraudulent activity, but we also do not support arbitrary policies that impose one-size-fits-all solutions on the patient-physician relationship. Unfortunately, the policies that have been enacted in many cases to curb the epidemic have caused suffering to patients with pain, and that includes chronic pain, cancer, and who need hospice and palliative care, as Kate alluded to a little bit earlier. The policies also have increased stigma, and they've harmed too many people. And even though exceptions for cancer, for palliative care, and other conditions have been written into statute or included in the explanatory text of a national guideline, the exceptions sometimes are only worth what they say on the paper, but they have to be followed and implemented consistently. And considering the practice environment, that implementation goes through many steps, whether it is the payer, the pharmacy chain, the PBM, and in other cases, the healthcare professional. Next slide. As a rule, just again, some level setting here, but the opioid epidemic is not just about supply of opioid analgesics. If it was, this chart would tell us a couple of things. First, keep in mind that prescribing started to decrease in 2012, 2013, and it's dropped considerably since then. Given the drop, it raises the question about whether opioid-related mortality has decreased, and whether non-opioid pain care has increased, and overall whether there's been an improvement in pain care outcomes. Those are rhetorical questions. I'm a lawyer. I like to ask questions that I already know the answers to. But opioid-related mortality has not decreased. Unfortunately, opioid analgesics have been vilified to such an extent that it has caused many of the problems that speakers throughout the conference have pointed out. Next slide, please. Just a quick, people have seen this chart in a variety of ways. I want to highlight something that a little bit different about this though. If you look at the years in 2016 was when CDC released its opioid prescribing guidelines. 2016, 2017, there was a tremendous rush of state legislative activity, and patients with pain, patients with substance use disorders, they need policies that address larger issues than just arbitrary dose and quantity limits for a single type of legitimate pain care. So we just want to keep the larger picture involved, and that includes treatment for opioid use disorder and many different harm reduction efforts. Next slide, please. Let's start with insurance companies and pharmacy benefit management companies. This is a survey from the American Board of Pain Medicine. And I encourage you to take a look at this, because if the argument is that patients, these are the entities that control access to non-opioid pain care, and if the argument is that patients need access to non-opioid pain care, you would think that insurers and PBMs would respond accordingly. But when we ask pain medicine physicians whether or not they've been able to increasingly prescribe or offer non-opioid pain alternatives, they have not. Routine prior authorization, benefit limits, restrictive formularies are part and parcel of a pain medicine physician's daily practice. And rather than just complain, though, this is where we think policymakers can and should take action to remove barriers to care. But part of that is making sure that they have this type of information. Next slide. During COVID, there have been some promising efforts. Next slide. Want to point out again, this is the whole big wax of what DEA has done. And the increased flexibility is really important. The AMA has been greatly pleased by this increased flexibility, but a few additional caveats. That these don't eliminate the incredible challenges patients with pain have had in finding a pain medicine physician in the first place. And the second one, governors actually, in many cases, have to adopt these DEA rules in full for the physicians to use them. And, payers not only have to pay for telemedicine encounters, they actually have to have adequate pain care networks and formularies. As Kate has mentioned and others have mentioned, the AMA also has received hundreds of stories from patients with pain having, incredible challenges in accessing evidence-based pain care. And these kinds of structural barriers to comprehensive treatment remain despite the beneficial policies from DEA. Next slide. That's one of the reasons that the AMA has taken some of the language from executive orders and DEA itself, developed model language that we would like to see state policymakers implement it. You can read this. We encourage any and everybody of the 200-300 people that are on the call right now, go ahead and use this. Share this with your state policymakers. Encourage them to actually adopt it. But next slide. Post-COVID next steps. I want to emphasize a point that these are the AMA opioid task force recommendations. And even though this is what the AMA has been urging physicians to do, last year we issued recommendations focused more on policymakers. To get at the broad aspect of that, this conference is focused on pain, but there are multifactorial policy issues that need to be addressed to resolve, the larger epidemic of insufficient pain care, insufficient access to treatment for opioid use disorder, and the vast number of harm reduction strategies that need to reduce harms across the board. Next slide, please. Again, small, another model bill from the AMA. Moving into the second half of 2020, this is model legislation designed to help patients with pain. There is legislation in a couple of states, including Colorado, that seeks to remove barriers to pain care. But again, the policies, are only as good as they are implemented. They first need to be enacted, but then they need to be implemented, and then they need to be enforced. The AMA is committed to doing that. We can't do it alone. We welcome your help. Next slide, please. And a social distancing, thank you very much. And I'd be happy to join my colleagues in answering your questions.
Okay, thank you all very much. That was really diverse and very interesting information. And we have a number of questions that have been submitted from the audience, so I'm going to try to tackle some of these. The first question, I think, Paula, in our preparatory meeting, you talked a little bit about the answer to this question. Could these practitioners also deliver remote services through telehealth, such as guided acupressure, guided self-massage, guided corrective exercise, and seated yoga? Some licensed behavioral health clinicians trained in MBSR, et cetera, have some of these in their toolkit also. What have you been seeing?
Yeah, I definitely think that my acupuncture colleagues are being very innovative and even starting to do some clinical trials around telemedicine and delivered things like acupressure, Tuina, having patients at home use moxibustion on different acupuncture points. And as a profession, I do see that coming forward. I think that what's tricky is the payment model, because I think acupuncturists and many things like massage therapy continue to be out of pocket pay here in the United States, although that's changing. These professions, I think, are very quick to get up to speed. I know the mindfulness community has been doing a lot of training for teachers on different types of delivery of telemedicine, conferencing. So I think that these allied health professionals who work with us are moving forward and stepping up to the challenge. But I think what I don't really feel like is clear is the payment models.
Okay, thank you. And Paula, I think this one may also be for you, but also for Andre, I think. Anxiety states for patients in general and pain patients in particular are expected to drive benzodiazepine prescribing. This is a particular concern when co-prescribed with opioids. Do we have any practical recommendations to limit harm in this area?
Yeah, my answer is quick. This is when I'm calling my pain consult because my familiarity with these medications are limited to newborns. I will point out that there are guidelines out there, and polypharmacy is a pretty massive issue. But the level of nuance, I guess I ran a series of methadone clinics. Many of our patients had polypharmacy, and most of the prescribers of the benzodiazepines usually were not our prescribers. So trying to minimize polypharmacy can be a real challenge when trying to communicate with other providers when you're legally or perceived to be legally not allowed to communicate with them. I would just point that out, and I think and we can get into a discussion about the policy constraints there and whether 42 CFR Part 2 is a flexibility that in addition to HIPAA should be considered waived, but I'll defer to Paulo and the actual clinical expertise there.
Well, it is true. I mean, I think that the primary care providers have their toolbox and what can they do over the phone. And one thing that they can do is prescribe medication. So I do think that we need to be aware of what are the tools that clinicians are quick to choose, and what are the tools that clinicians have access to, feel safe prescribing, and are going to help that patient in the moment. So I don't actually know if we have any data about increasing prescribing of benzodiazepines. I do know that for my own colleagues, many of them are starting patients on antidepressant medications during this difficult time. And then myself, even this morning I had a call with a patient doing telemedicine visits who had anxiety, and I was working on the non-pharmacological, so apps on her phone that she could use, Sleepio and apps for reducing stress, things for deep breathing, having her deep breathing, things like chamomile tea, taking a warm bath, going outside, being in nature, trying to create a toolbox for her that she can do at home that's safe for her.
Yeah, and I will tell you, as a clinician myself, I've spent a lot of time over the last few weeks really working hard on the anxiety with patients, trying to teach them some guided imagery exercises via telehealth, as well as referring to them to a whole bunch of online resources that are out there. So I think there are plenty of opportunities. And Andre, the reason I kind of tagged you in the beginning was I was thinking about that visual reality application that you talked about early on. I think those are some things that could be available for patients as well.
Yeah.
So Kate, a question for you. It's asking about the emerging literature and practitioner observations regarding palliative care and the multiple obstacles telehealth presents insofar as access to specialized care and support. Do you have anything more to say on that?
Well, it's a bit of beyond my bailiwick, honestly. So I don't know about emerging studies. I've certainly heard from palliative care practitioners, and I do know from my disability background that there are a number of different types of conditions that would make telehealth, challenging without an additional support person in the room assisting. But I'm not aware of emerging studies. I've certainly heard anecdotal reports.
Okay. Andre, a question for you. You talked about the need to expand Medicaid and to make some of the changes that we've seen in Medicaid permanent. During our next panel, we have someone from CMS who will be available on the panel. Do you have any words of advice for how to do that, especially in the context of some of the budget deficits we're racking up now?
Well, yeah, with Medicaid expansion, I mean, that advice is kind of hard to give because it's such a polarizing issue, and it's either you follow science and care about your state budget or you don't. And that's the kind of dividing line between Medicaid expansion. I think that, and I answered this in the Q&A chat, with regard to how do we afford so many more people going on Medicaid and increase in FMAP or Medicaid expansion. I think that the context that's important to keep in mind is that it's in expanding Medicaid or increasing spending on Medicaid is the lowest cost investment possible from a healthcare perspective, because that healthcare demand is a growing demand. It has to be addressed one way or another, and it has to be paid for one way or another. Medicaid is by far the most efficient way to do it. It's probably too efficient because providers need to be paid more. And we can get into the whole discussion about the ideal state for payment, whether it's Medicaid or beyond, but tying outcomes to payment, particularly around chronic pain, where there's so many modalities and so many providers. And so there's a lot to that, but when it comes to Medicaid expansion, it's very simple and very black and white. That it is the correct thing to do from a fiscal responsibility perspective and from a ethical and public health perspective.
Thank you. Thank you all for the questions you were submitted. The ones we weren't able to get to, we will get to after the symposium. And I think it's time for the next break, so I'll turn it back to Amy.
Thank you.
Thank you, Bob, and thank you to all the panelists. This was just an excellent panel. You put so much information forward in a short time so well, and so many questions were generated. I know some of you have started to answer them, but we will, as Bob said, get them back to everyone. It's just sounds like we have a great opportunity to share a lot of resources. So thank you all. Quick break, bio break, snack break, move around, and we will be starting again at 1 o'clock Eastern. So it's going to be another 2 great panels after that. So thank you so much, and we'll speak with you shortly.